I thank the Committee of Comics and the American Dental Congress for the invitation. I had been here 2 years ago, 2013, for the AAO, and it was a nice experience. My subject today is about congenitally missing teeth and orthodontic treatment. And this is my city, Riyadh, Saudi Arabia, where I come from. And if I'll just talk about myself, I graduated from King Saud University Dental College. And I got my ortho degree certificate. It's from the Saudi Commission of Health Specialties, and it is a 5 years clinical certificate program. And this is where I practice, the Security Forces Hospital at Riyadh also. And here are some of pictures of the dental department where I do work there. Also, this is some pictures of the private where I practice as part-timer. You can see my assistants. They are preparing a patient for bonding. And this is one of my patients, and she was happy about treatment. So in this lecture, we'll talk about introduction, definitions, etiology, clinical features and complications, diagnosis and treatment planning, treatment modalities, and orthodontic space management, and the maxillary lateral incisors and the lower second premolars, which they are the most common congenital missing teeth, then the summary. So let's go ahead and we'll start with the introduction. We know that orthodontic patients usually come either with orthopedic discrepancy, which is skeletal class 1 or class 2 or class 3 between maxilla and mandible, or with teeth jaw discrepancy, like in crowding, or both. Usually they have normal teeth, count and anatomy, but sometimes they have missing teeth, either extracted or congenitally missing. So it's a challenging because of it is an aesthetic problem in the anterior region, and it's a function problem in the posteriors. So definitions, if we go through it, we know that dental agenesis is the congenital absence of a tooth. If it's referred to developmental abscess of one or more teeth, we call it hypodontia. And if it's multiple teeth, we call it oligodontia, or the complete absence is anodontia. Of course, the classification of the hypodontia could be mild to moderate if it's 2 to 5 congenital missing teeth, and severe if it's 6 teeth or more. Prevalence of hypodontia, it's relatively common in the permanent dentition, from 3.5 to 6.5% in the majority of the population. And it's less in the deciduous dentition, about 1%, regardless of the gender, male or female. In Saudi Arabia, a study by Professor Al-Imran in 1990, he estimated the percentage to be 4% in children. Most commonly missing teeth, usually the distal tooth of each morphologic class. That's mean for the molars, the third molars, premolars, the second premolar, and the maxillary lateral incisors. Etiology could be environmental factors, which include irradiation, tumors, rubella, or thalidomide, physical obstruction or disruption of the dental lamina, space limitation, a functional abnormality of the dental epithelium, or failure of initiation of the underlying mesenchyme, or use of drugs and during pregnancy. Otherwise, the second reason could be genetic factors, which are the modes of inheritance, which is actually still unclear how it could be inherited. Many authors have suggested the Mendelian patterns of inheritance, while others, they said that hypodontia may be the result of interaction of many genetic factors. Could be both. Multifactorial model in which genetic factors play a major role, but the environmental factors are also included. So these are some photos. This photo and the radiograph, we can see a missing lateral, upper right lateral incisor here. Here we can see a missing, on the second one, we can, actually it is messed up a little bit. The pictures are, we can see in the lower, the second one, lower, second premolars. The third one, central lower incisor. Beside also, we can see the crowding of the upper in the second case. Here we can see a missing upper left lateral incisor in the first one. The second one, we can see also bilateral missing lateral incisors, both sides, right and left, and on the lower we can see the second premolars, permanent second premolars are missing. So clinical features and complications. Number of features has been shown to be associated with hypodontia, which is microdont, small tooth, conical in shape, tapered teeth, or absence of other teeth. Also increased freeway space, the developmental failure of alveolar bone, which is resulting in apparent atrophy of the ridge and lack of posterior support. We could see also retained primary teeth, which is making 65.7% of all hypodontia patients. They had enclosed primary molars, compared only 1.5 to the control group. Taurodontism also, it's more common, with a percentage of 34.3 compared to 7.1 in the control group. Also, the maxillary lateral incisors are microdont or absent. When they are like this, the maxillary cuspids may follow an ectopic, we call it ectopic eruption, due to, of course, a bigger space. Enamel hypodontia, disturbances in spacing, or delayed tooth formation, prolonged primary tooth exfoliation, and delayed eruption may associate with hypodontia. Diagnosis and treatment planning. Early recognition of hypodontia is vital to provide adequate treatment to prevent malocclusion, particularly other dental defects, and also early diagnosis of hypodontia can reduce orthodontic complications and assist in the planning treatment. Of course, diagnosis of congenital absence of teeth needs to be verified. How we verified that? We can take sample in X-ray examinations, or if the tooth is uninterrupted, or ascertain that the tooth has not been present before and extracted, and that we can take it from the history of the patient, or can be by a long follow-up. Diagnosis and treatment planning, we need an interdisciplinary team and determine space requirements, restorative and periodontal adjunctive treatment needs, and diagnostic wax setup. It's very important in these cases. Treatment modalities, we have factors to be considered when selecting the treatment options. Severity, how severe is the hypodontia? How many teeth are missing? Space condition, age of the patient, young or adult, adolescent, skeletal relationship, which is skeletal class 2, class 3, or class 1, and type of sagittal occlusion, class 1 or class 2 also, the interocclusal space, axial inclination of the teeth is very important, proclination of the anterior teeth, presence or absence of third molars, caries situation, and root resorption tendency, the numbers and condition of the retained teeth, and the condition of the supporting tissues. For the permanent teeth, the following treatment modalities may be considered during treatment planning. We have timely extraction, which is space closure by spontaneous drift of the teeth. We call it guided eruption. And we have orthodontic space management. We have auto-transplantation of developing premolars. And we have prosthetic appliances, which is the conventional way. Orthodontic space management, there are two choices for treatment, either in the anterior or in the posterior. It's the same. In the anterior space, we have opening space for the prosthesis or close the space by canine substitution. In the posterior also we can open space for prosthesis or posterior space closure. So in the anterior space opening, we have indications, which is class 1 in class 1 cases, class 3 malocclusions, flat profile, and in case of spacing, canines are much larger than the first premolar. Okay? So there is a big difference. And contraindications include class 2 malocclusions, extraction cases, and crowding. In these cases, we should not do a space opening, the opposite. Okay, advantages. What are the advantages? We have ideal aesthetics of canine and premolars. We have ideal functional occlusion. And the disadvantage, of course, is the opposite, replacement of restoration over time. Gingival recession leads to poor aesthetics and potential eruption of adjacent teeth over time. Difficult to achieve ideal aesthetics of prosthesis and difficult long-term management of gingival aesthetics, because we know that dehiscence could happen, and with eruption, the implant will be showing or whatever is the prosthesis. So let's see the indicators of the anterior space closing, indications, crowding, dentoalveolar protrusion, class 2 malocclusion, which is actually the opposite of opening the space. Increased overjet, canine and premolar similar size, small white canine, which is will be difficult or different. Here it will be actually the same. We can close it, reshape it as to be lateral incisor. Contraindications when it's generalized spacing, class 3 malocclusions, because we need to expand the maxillary arch in this case, and we should open it. Large color difference between canine and incisor, so it's not suitable. Large size difference between canine and first premolar also. Advantages of closing anterior space: biologic compatibility, of course. Permanence, it's not a prosthesis. Aesthetic papilla also will be reserved. And eruption rate similar to adjacent teeth. Recession over time is similar to adjacent teeth. The disadvantage, relapse. The space could open after ortho treatment. May be difficult to achieve canine-guided functional occlusion. More difficult to achieve ideal aesthetics of substituted teeth. This is a picture from Saudi Arabia. Some people still, it's only desert and camels, yeah? Anyway. Maxillary lateral incisors, important factors: the amount of space, patient's age, type of malocclusion, and condition of the adjacent teeth. And there are 3 also treatment options that exist for replacing missing lateral incisors. We have a canine substitution, tooth-supported restoration, and the last one is a single tooth implant. Of course, the choice should be the least invasive and satisfies the expected objectives. And actually, the orthodontist here, he's the one who decides. He has the key role. Canine substitution can be excellent aesthetic treatment option for replacing missing teeth, missing laterals. And how to select? There are specific dental and facial criteria must be evaluated. First, the malocclusion and the amount of crowding, the profile of the patient, canine shape and color, and lip level. Malocclusion and the amount of crowding, in class 2 cases, malocclusion with no crowding in the mandibular arch. Okay? So in this case, we close the space and substitute the canine with the lateral. And also in class 1 malocclusion with sufficient crowding for mandibular premolar extraction. And the anterior tooth size relationship is important. So the excess should be reduced from the canine to replace the lateral incisors. Here we can see the profile. Here it's wanted, of course. What we need is a balanced, relatively straight profile, which is ideal. A mild convex profile also may be acceptable. But a patient with moderately convex profile and retrusive mandible with deficient chin prominence may not be a good candidate. Canine shape and color, the ideal lateral incisor, substitute the canine should be the same color as the central incisor. The canine should be it's narrow at the cemento enamel junction. Buccal lingually and mesiodistally. Has a relatively flat labial surface and a narrow mid-crown width, buccolingually. The lip level, which is the smile line or the mucogingival line, which is the gingival margin of the natural canine, should be positioned slightly incisal to the central incisal gingival margin. Occasionally, a gingivectomy may be needed, as in this case, to be performed to properly position the marginal gingiva. Treatment, of course, here we don't take the incisors level as the reference for us. We take the mucogingival level. So the orthodontist should put the brackets on the right position. And as we see in this case, the brackets of the canine should be placed at a distance from the gingival margin that will erupt these teeth into the appropriate lateral incisor vertical position. Then it can be restored. The second choice is the tooth-supported restoration. And we know that these are when the teeth supported already, the tooth had, the patient has already a prosthesis for replacing that one. This could be a choice, and it has three primary types. We got resin-bonded fixed partial denture, cantilever fixed partial denture, and the conventional full coverage, of course, fixed partial denture. But the primary consideration is the conservation of the tooth structure with the good aesthetics. Tooth-supported restoration, which is depends how we determine the appropriate space, and there are 4 ways to determine. Use the golden proportion. We know that this ratio is 1 to 0.618, each tooth to the next one. And this is very important, determining how much space is needed for the next tooth. Okay. The second way is use the contralateral incisor as an indicator in case if it's present and it is normal in shape, or use the Bolton analysis also. And diagnosis works up. Actually, this is the most predictable guide for the determining the ideal space, but you need a good technician. Resin-bonded fixed partial denture, which is the most conservative tooth-supported restoration, and it's the classic design. It doesn't use pins, okay, or grooves, but success rate is from 54% failure rate over 11 months to a 10% failure rate over 11 years. Debonding is most common problem, of course. The criteria for optimal aesthetics, we have the position. We need a shallow overbite and upright abutments with shear forces can withstand more forces than proclined ones with tensile forces. Mobility also, mobile teeth are contraindicated. Thickness and translucency contraindicated, and thin abutments with reduced bondable surface areas. And any occlusal parafunctions contraindicated, or in patients with signs and symptoms of parafunctions like TMD or something. Cantilevered fixed partial dentures, second most conservative, tooth supported. The canine is ideal abutment due to the root length, of course, and the crown dimensions. Success is not dependable on the abutment proclination and mobility. Okay. Sorry for that. We got the last or third choice, which is a single tooth implant. It's one of the most common treatment, of course, and it has a high success rate. If the implant supported single tooth replacements, and the advantage is the ability to leave the adjacent teeth untouched, of course. So it's also very conservative. But implants cannot be placed until facial growth is complete. This is a big disadvantage when I have adolescent patients, and we have to wait actually for the facial growth sometime. Implant site development, we got the congenital missing lower incisor. Lateral incisor is discovered usually in patients between 7 and 10 years of age. And if the permanent canine is allowed to erupt mesially, its large buccolingual width will influence the thickness of the edentulous ridge, When the permanent canine is orthodontically moved distally, an increased buccolingual alveolar width is established. So we do this actually. We use the canine here to preserve the bone, the alveolar bone, due to the deficiency or the missing lateral incisors, and we distalize it to open the space for the implant. In the space appropriation also, most predictable way is diagnostic wax-up, as we said. Generally, the width ranges from 5 to 7 millimeters. For the development of the papilla, we need 1.5 to 2 millimeters of space between the head of the implant and the adjacent teeth. Also, it's important to have adequate interradicular space, which is minimum of 5 millimeter, to have approximately 0.75 millimeter of bone between the implant and the adjacent teeth. In class 3, we can see the wagon wheel, which is effect. We can see that's mean when the roots are more close to each other and the crowns are far away. When we put the implant, when the facial growth is complete. If an implant is placed before a patient has complete his or her facial growth, significant periodontal, occlusal, and restorative problems may be created. Of course, serial cephalometric radiographs are the best way to make sure the facial growth is complete by taking each 6 months or 1 year interval. Interim or temporary tooth replacement, tooth placements are after ortho are done for that area by the adjacent teeth for a short period of time, but for a long period of time, a resin bonded fixed retainer, fixed partial denture can be used. This is Riyadh City. You can see how changes are. And the other subject is the lower second premolars after the lateral maxillary lateral incisors. We have the congenital absence of mandibular affects many ortho patients, and the orthodontist make the proper decision at the appropriate time. If it's come early, this could be good for the patient, and if it's wrong, it will affect the patient for his or her lifetime, because it will affect on the profile, on the teeth positions, occlusion, everything. Treatment options: we have guided eruption, we have orthodontic space closure, we have space maintaining, and tooth replacement. And the last choice is auto transplantation of a developing upper premolars. What's the guided eruption? We know by extraction of the lower second premolars, and early the spontaneous space closure happen. The result in the mandible is not good as in the maxilla due to the jaw nature, the bone nature of the jaw. The treatment considerations depend on the patient's age, the stage of development of the adjacent teeth, the condition of the deciduous predecessors with regard to root resorption and infraocclusion. More treatment options are available for younger patients, of course, but after age 9, it becomes more limited. Spontaneous space closure is not available as before. And to minimize tipping of the adjacent teeth, it's advocated to extract the retained deciduous second molar before the eruption of the first permanent molar to allow for spontaneous space closure by Sedimar. Okay, so orthodontic space closure of the dental space would be advantageous if the patient has crowding in the opposite dental arch. In patient with protrusive facial profile, additional anchorage is required, of course, either extraoral or intraoral, so you don't have changes. Berkeley and Bennett, they found the retained deciduous second molar undergo resorption between ages 11 and 20. 60% of their mesial root and 46% resorption of their distal root between these years. But usually after the age of 20, the retained tooth and the adjacent teeth are all affected by this choice. Ankylosed primary molars, this is a problem also. We can see primary molars ankylosed is, it's not very common, but as the adjacent teeth continue to erupt, it is happening actually. When it happens, it's difficult to adjust. Even the extraction is very difficult of these primary molars. Okay, So they became below the level of the adjacent teeth, and the best method to detect enclosed is a bite wing, of course, radiograph, and see the bone level, mesial and distal. The decision to extract the enclosed depends on the age, gender, and the presence of a permanent successor. Space maintaining and tooth replacement. The primary second molar is an ideal space maintaining for the teeth, but it will need, of course, to be reduced mesiodistally in the size. And the first choice of restoration for a congenitally missing mandibular premolar should be a single tooth implant, but the appropriate age of the implant placement is determined by the cessation of the vertical facial growth. And it's advantageous also to reduce the width during the ortho treatment, of course. Here we can see how is an orthodontic implant site developed. We can see that there is a missing second premolar, right second premolar, and we extracted already, the case had been extracted, the enclosed, that is an enclosed 5, lower right E, and after that, after it was extracted before, it happens that mesial drifting of the molar, space was regained again, and an implant was done. The auto-transplantation of a developing upper premolars, this can be also a good choice of replacement, transpositioning, transplantation of teeth. It could be allo or auto. Allo, it could be from different person, another person, which is, of course, not used anymore. Auto transplantation from the same person involves moving a tooth from one area of the mouth to another. It has been reported widely during the past 40 years, and it's becoming now a big subject and for discussion, and a lot of people are actually believing and doing it. Early reports recommended transplanting when 3/4 of the root length has developed. Of course, the question when we have to transplant. Preserve to preserve the pulp vitality to obtain adequate root length. But sometimes, of course, we have to do a root canal and block the canals. Advantage, we can use this for orthodontic reposition and no space maintenance needed. There is a case here. We can see the missing bilaterally second permanent premolar, and we can see the crowding of over no space for the upper second permanent second premolar. So they were extracted and planted in the mandible, or transplanted, I mean. And so case is solved, no need for an implant there. Summary, orthodontists very frequently, they face patients with congenitally missing teeth. The most common are the maxillary, lateral incisors, and the mandibular second premolars. The treatment decision must be made based on eruption pattern, growth potential, tooth position, and tooth health. An interdisciplinary teamwork is needed for the best treatment plan. Early diagnosis and treatment of ankylosed primary second molars also may be important for the periodontal and the restorative treatment of the adolescent patient. Monitoring patients in the mixed dentition is essential to preserve various treatment options in the future. Here is, we have the Saudi Orthodontic International Conference. It's going to be on 26, 27 March 2016, next year. So in Riyadh, I invite you, if somebody is interested, you are welcome to come. And it's a chance to see Riyadh, if somebody did not before come. Also, we have desert safari there, it's good. Thank you so much. Any question? Thank you for your attention. I hope it not pass the time. Okay. Okay. Thank you.
Okay. Thank you, Dr. Alharbi, giving very detailed overview of orthodontist possibilities and procedure with the missing teeth. Is there any question from the audience? Yes, please.
Doctor, what's your experience with over-retained teeth? I'm sorry, it's not part of your talk, but sorry. I have a lot of patients with over-retained central incisors, deciduous, sometimes molars, sometimes canines, and there are no succedaneous teeth present in the mouth at all. Means the other teeth which should have come,
Yeah.
when you take an X-ray, they are not there in the...
Yeah, there is no successors. Yeah,
Yes.
this is
So
the
what
case.
do you do with such? You just keep them or what?
Actually, it depends on the case, ma'am. This is as I said, that if it's the skeletal relationship is a class 2, class 3, is there crowding, is there spacing, and also the age of the patient is very important. So we should evaluate each case on a time, but according to the occlusion also. Yeah, that will make us, we cannot say from now. And also the condition of the tooth. Some teeth, they can stay. So patients 30 years or older, and they have still those deciduous molars there. And it's fine, yeah. So it depends on the case, actually.
Doctor, one more question, sorry. You talked about missing laterals, which is very common. So till the bone is formed and the facial growth is completed, wouldn't a partial denture be a better alternative than anything else?
Yeah.
If a child is very small,
It
say
could
7
be.
or 8
yeah,
years
but
old.
you should do ortho treatment first, so you regain the space. Yeah, otherwise, so usually the space, the tooth is next teeth. You know, teeth are moving everywhere. When I have the chance, if you remove the opposing tooth, they supra-erupt. If you move the adjacent, they move drift mesially or distally. So yeah, ortho treatment could be done, and the choices could be, one of it is the partial denture acts also as a retainer for the ortho, and we do that, yes.
Yes.
I don't have just comment. This was excellent presentation.
Thank you so much.
My orthodontic residents, for a couple of weeks, we already are looking for the Paxton and MSX1 mutations in patients with
Yes.
missing teeth. And it's really, showing us that certain groups of teeth are linked to certain
Yeah.
mutations. And
Yes.
our kind of goal is if we have a family where we can see several individuals affected, making sure that young patients,
Yeah.
we can, when we don't know what's going to happen with permanently, we can still make a prediction based on the mutations which are in
Which is good. Yes.
and then we prepare for them.
Very good. Excellent. Because as you said, early diagnosis is very important.
Papers or whatever we can do to actually protect the normal facial growth.
Exactly. Yes.
Especially in anterior area, the facial growth is really compromised.
Yes.
Just a comment. So maybe,
Thank you so much.
do some of these studies which they did and
Good, that's good. I have a lot of cases actually, but during the shortage of time, and it's ongoing cases and cases I have finished. Dr. Tamimi, Abdulaziz Tamimi, who missed, he should be the second speaker. He's working with me actually. We have cases together. He's a prosthodontist. So we work in the same place and we share cases, and really we have good result cases. But most of the patients are adults actually. I have now I have a lot of patients. More of my patients are adults, more than actually. Yeah, the new trend. And of course, their children mostly will be affected. Yes, no, that's very, very, very important issue. Yes, thank you so much.
we have a very simple method to actually extracting DNA from saliva.
Yeah,
So we can share this,
sure.
your students or residents can
Yeah, I have residents also. Yeah, that's good. Thank you so much. Thank you, appreciate it.